Hello, everyone. Welcome to our June ICARE case conference. I'm Tua Pal, and our topic today is really hormone replacement therapy use and the hereditary breast cancer genes. And I just wanted to highlight some of the things that come up in my own practice. I do feel this is a really timely topic. So in BRCA carriers, is hormone replacement therapy an option after uh, risk reducing salpingo-oophorectomy, and really thinking about it premenopausally versus around the age of menopause, and then status of the individual, whether they're unaffected versus affected with breast cancer, and then if affected with breast cancer, is it hormone receptor positive? Is it triple negative? So again, I think these are the types of questions that I've come across in my practice that patients really want guidance on. And then looking at check two carriers, is HRT an option? And if so, what type? And really to manage menopausal symptoms, um, mainly in the situation where someone is unaffected. So I wanted to start with a case like we usually do. So here, this is a patient that I had seen several months ago, 47-year-old with a family history of breast cancer. Her mother passed away from breast cancer, and she has a living aunt with breast cancer. Just as an aside, her husband and her daughter had multiple endocrine neoplasia type 2 status post-thyroidectomy, but that was separate from what we're discussing here. So she is status post total abdominal hysterectomy, bilateral salpingo-oophorectomy, and was having severe menopausal symptoms and was trying to get HRT, but was really not having much success in getting it prescribed for her. She was encouraged to take tamoxifen, but she was concerned that this might make her symptoms worse. She did start taking gabapentin. She also had an episode of recurrent major depressive disorder. So again, this was a huge lifestyle issue for her. Now, looking at her risk estimates based on CAN risk, you can see here from her current age to over the next 5 years, almost 8%, next 10 years, 17%, and then to age 80 was 46%. So really the questions were, what does the data tell us regarding HRT in patients like this? Specifically, is HRT an option for this patient? And if so, what would be the formulations to consider? So I'm going to introduce our guest expert and then turn it over to her. So um, our guest expert today is Dr. Joanne Kotsopoulos, who is a scientist with the Familial Breast Cancer Research Unit at Women's College Research Institute. She's also the Canada Research Chair in Hereditary Breast and Ovarian Cancer Prevention. She is a Hereditary Cancer Advisory Co-Lead at Pete Gilligan Center for Women's Cancer at Women's College Hospital and Associate Professor at the University of Toronto. Joanne is a great friend, so I'm really excited to have her teach us about this really interesting and timely topic focused on HRT and hereditary breast cancer. So Joanne, take it away.
Okay, thank you, Tua. I'm happy to be here to talk about, I think, what we all think is an important topic to help improve management of high-risk individuals, whether they are affected or unaffected. And this is something our team has really been interested for years. But of course, this picture from the New York Times article from a few years ago, we know that menopause is a hot topic lately. That was really ignored ever since the Women's Health Initiative trials published an increased risk of breast cancer with estrogen and progestin containing HRT. So we won't get too much into the, perhaps underprescribing of HRT for unaffected women, but I'm just going to actually just provide some evidence in a BRCA context. And really provide a really quick overview, which I'm sure a lot of you already know about high-risk populations. And then I'm going to present some really, really recent studies that we're working on that are really in progress. And so we are looking for critical feedback, especially from clinicians, because of course I am not a clinician, I'm an epidemiologist. And so it's nice to get input, of course, from our clinic friends. So to just get started, of course, I think everybody in this audience probably knows carriers have high risk of breast and ovarian cancer, especially BRCA1 tend to have an earlier age at onset. Salpingo-oophorectomy strongly recommended, of course, to prevent not only ovarian and fallopian tube cancer, but of course, this improves all-cause mortality in these populations. We need to think about the fact that BRCA1 cancers tend to be typically hormone receptor negative, unlike the BRCA2s. And so we really need to continue to think about how we can impact mitigate the impact of early surgical menopause when we think about both affected, so women who have had breast cancer, and unaffected high-risk populations, because often these women are being forced into early menopause because of surgery, because of chemotherapy, or both, and they have a long life to live ahead of them. So now that we've figured out the best way to prevent them from dying, we want to enhance quality of life and mitigate some other non-cancer related outcomes. Okay, so as I already mentioned, I framed this next few slides as clinical dilemmas. I'm going to start with affected carriers, so women who have had a breast cancer diagnosis, and then I'll go to the second clinical dilemma of can we use HRT safely in unaffected carriers? And really, the questions are similar, but the endpoints are different at some point. So for women who have had a breast cancer diagnosis, we really need to understand whether initiating HRT or MHT, I know there's some back and forth with what wording people prefer, but does hormone use increase the risk of dying? And does this relationship vary by mutation or formulation? And then similarly for unaffected women, does using HRT increase the risk of developing breast cancer? And is there any variation by mutation or formulation? And so just quickly, all the data that I'm presenting comes from a large international collaboration, including sites from all over the world, including ICARE. We conduct epidemiologic studies where we collect detailed information from carriers using a detailed questionnaire. We try to do medical record review for all incident cancers, and we currently have over 6,000 carriers that are under our follow-up. So first dilemma, does HRT use following a diagnosis, of BRCA breast cancer, increase the woman's risk of dying? So this is really a really early analysis. We're still trying to increase numbers, but it's giving us some nice data to work with. So I'm sure all the clinicians know that are in the audience know that hormones are contraindicated following a breast cancer diagnosis. But this is really based on data from very few studies that showed an increased risk of local recurrence in contralateral breast cancer. And of course, most of these were postmenopausal women, likely from the general population. Oh, sorry, my slides are moving. And there are no studies that have been conducted looking at the impact of hormones on survival in this high-risk population. So Tu already gave us a case example, and I also wanted to include a case example because I think this is what's really the burning question often in the clinic that the clinicians are faced with. You have a BRCA1 carrier diagnosed with stage 1 cancer. It is triple negative, and she's been diagnosed at age 38. She's had her systemic treatment, radiation perhaps, maybe not, chemotherapy, and she's had a bilateral oophorectomy. But now she's presenting with severe menopausal symptoms, decline in overall quality of life. So can she take HRT? So we decided to use our large database and and this was really, we didn't think we would find any women who used HRT in our data set, but we took a look anyways, fortunately. And so we looked at our database to see if there were any carriers diagnosed with breast cancer under age 50 who did not have any other cancer before their breast cancer, had not used HRT before their breast cancer, and they were under active follow-up, and they were still alive within 3 years of their diagnosis. And so, because we can't really do an actual randomized controlled trial on this topic right now, we thought we'd mimic a trial. And I don't know how many people are really up to date with methodology for epidemiologic studies, but there's a lot of interest in this target trial approach where you use large observational databases and you mimic a clinical trial. So in this case, we took all the cases that were under age 50. There were 3,890 women with an early onset breast cancer in our database. 3,169 had not used HRT after her diagnosis, and 349 did. And so what we did was we matched these women on as many factors as we could, including age, date of diagnosis, invasiveness, treatment, and this resulted in 183 matched pairs. So thinking about this as a randomization, these women were as similar as possible, and then they were randomized or did initiate HRT, and those that did not. And for the purpose of time, I won't get too much into the underlying epidemiology of this, but this figure just basically summarizes that we have women diagnosed with breast cancer, those who are exposed are the ones that did initiate HRT, the unexposed are those that did not initiate HRT after diagnosis, and then after matching for various factors, we were able to follow them over time for death. So this table here summarizes the baseline characteristics of the women who did and did not use HRT. And of course, many of these are exactly the same or very similar because of our matching criteria. There were a few differences by country of residence, and the follow-up time was significantly lower in the HRT group. So treatment characteristics, we did match on oophorectomy, chemotherapy, tamoxifen use, and we still see no difference by surgery or radiation. So now this was kind of like the main take-home message of the study. So then we compared vital status and cause of death in women who didn't and did initiate HRT. So in the no HRT group, at the end of the follow-up, 22 women had died. And this was significantly higher than the 9 women who died in the HRT group. And then when we plotted 10-year survival, so looked at survival over time in the 10-year follow-up. Sorry, there's a code blue. Sorry if it's loud. Women who did use HRT here in the yellow had a significantly better survival than those who did not initiate HRT. And the risk of death, when we did our multivariate modeling to account for some of the factors that did differ between the groups, showed a significant 70% reduction in death in all the women combined and for the invasive cancers. The association with DCIS was not significant, but there were much fewer women with DCIS in this cohort. So, of course, there are various and several limitations so far. This is a preliminary study, so the sample size is very small. The follow-up is still small. And I'm sure what is glaring right now is that we didn't account for tumor characteristics. We're currently trying to get detailed information on stage, nodes, and other factors, and really look at this in a larger sample and also by BRCA mutation type. So that was our study, our preliminary study, looking at HRT and risk of dying in a woman with breast cancer. So now for the purpose of time, I'm going to go into the clinical dilemma 2, which is a really important question also, is whether or not HRT increases the risk of breast cancer in women with a mutation. And so without getting into the history of HRT and its impact on breast cancer risk, in a nutshell, I think most of the data in non-carriers, when we look at observational data, points towards an increased risk with estrogen or E+P formulations in the general population. But of course, there's variation by route of administration, formulation type, and the effect tends to be stronger for the combination E plus P. So really thinking of the progestins as perhaps what is driving the increased risk of breast cancer. And this has been of interest for myself and our team because we know that progestins play an important role in BRCA1 development of breast cancer when we look at the underlying biology. And so for this study, we also conducted a target trial analysis. So again, thinking of this as a randomized controlled trial using observational data. So all the women were carriers, had no history of cancer or a bilateral mastectomy. They were under active follow-up and had entered menopause, either surgical or natural, by the end of their last follow-up. So similar to what I showed before, we matched the 3,000 women who were eligible for this analysis by important characteristics that we know may influence the results. And this resulted in 676 pairs of women who did and did not use HRT. There was about 5 years of follow-up in the study. And then the no HRT group, about 19% developed breast cancer. And this was significantly higher than the 13% in the HRT group. So a higher rates of breast cancer in the no HRT group. When we look at cumulative incidence, so cumulative incidence of breast cancer over the follow-up period, again, we see significant differences with lower incidence, about 24.5% in the HRT group compared to 43% in the no HRT group. So of course, we need to think about formulations because there's such differences when we look at the trial data with estrogen versus estrogen plus progestin formulations. And for this analysis, we looked at this relationship by BRCA mutation because we had more power. And we can see right away that there's actually an inverse relationship between the use of E alone HRT and breast cancer risk. Stronger for BRCA1 than BRCA2, but again, much smaller numbers in the BRCA2 group. But what's interesting, and this is different than our first publication on the topic, is that there was no impact of estrogen and progestogen containing HRT on risk of BRCA1 breast cancer. And we were not sufficiently powered in our BRCA2 analysis. So I hopefully didn't talk too fast, but I'm going to summarize the take-home message based on what I've reviewed. So for clinical dilemma 1, where the women had a breast cancer diagnosis under age 50, our preliminary findings suggest no increase in the risk of death with MHT use. Of course, thinking about all the limitations that we're still trying to address and needing to conduct larger analyses with more clinical and pathologic information. Clinical dilemma 2, where the women are unaffected, and of course we know most of these women are having a new oophorectomy, so are being forced into early surgical menopause. Our findings suggest no increased risk of breast cancer with any HRT use, and in fact, a protective effect of estrogen alone. And we are still conducting some analyses by tumor characteristic and formulation. And as we discuss these cases, we also have some interesting data, but the numbers are small with the newer formulations and by method of administration. So using a patch versus an oral formulation. So just to summarize, I think our key takeaways is that we really need to work towards conducting well-powered and more contemporary analyses. We can't be relying on archaic data or data from the general population when we think about carriers who are diagnosed at a young age or forced into early surgical menopause. And I think we need to think about the downstream effects of early surgical menopause. We can't assume that because we prevented cancer, that's enough. We don't want to be increasing other chronic diseases that may be influenced and helped by using HRT, and really taking an evidence-based personalized approach to menopause management that may include HRT in either affected or unaffected women. So just to finish off, I think most of our carriers, I think of a woman like this who's young, managing life, managing families, jobs, and then everything that comes with having a mutation, and we really need to do better. And so I'm thankful to all our collaborators, including Tua. This is a big collaborative effort, many years of dedication in collecting this data. And our lovely team here in Toronto, and to all of you for listening. And I'm looking forward to our discussion.
Thanks, Joanne. That was great.